Welcome to Medical Rocket, your high-yield launchpad for PLAB, MRCP, and USMLE success. Blood transfusion isn't just a routine order, it's a clinical judgment call. And today, we're locking down the must-know indications, components, and complications, the way top scorers do. Acute blood loss? Transfuse packed red cells if hemoglobin drops below 7 grams per deciliter, or if the patient is hemodynamically unstable. Chronic anemia? Transfuse if HB is under 8 and the patient has symptoms, angina, dyspnea, or worsening fatigue. Pre-op in cardiac patients? You may need to transfuse if HB is under 10. The heart hates low oxygen delivery. Now, what if platelets crash? Platelet count less than 10,000? That's dangerous. Risk of spontaneous intracranial hemorrhage. Give platelets. INR maybe 1.5 before surgery? Don't send them to the OR bleeding. Give FFP. Let's match components to their indications. Packed RBCs. 300 milliliters, used for anemia and acute bleeding. Expect a 1 gram per deciliter HB rise per unit. Platelets. 200 to 300 milliliters. For thrombocytopenia, DIC. No cross-match needed, but ABO compatible is ideal. FFP. 200 to 250 milliliters. For coagulopathy and warfarin reversal. Contains all clotting factors but no platelets. Cryoprecipitate, 10 to 20 milliliters per unit. Loaded with fibrinogen, factor VIII, VWF, used in DIC or fibrinogen less than 100 milligrams per deciliter. Now, test yourself. HB 6.5. With hypotension after trauma, give packed RBCs. Platelets 8,000 in a chemo patient, no bleeding. Still transfuse. Spontaneous bleeding risk is high. INR 2.2 before paracentesis, correct with FFP. These decisions save lives. They also rack up exam points. Hit subscribe, stay sharp. This is Medical Rocket. Now with the must-know transfusion complications, compatibility rules, and safety strategies for PLAB, RCP, and USMLE. Blood matching non-negotiable, ABO and RH compatibility is essential. O negative is the universal donor for red cells. AB plasma is the universal plasma donor. And cross-matching? It checks for recipient antibodies against donor red cells. If you skip it, you're asking for a disaster. Now let's hit the transfusion reaction chart. This is prime exam territory. Febrile non-hemolytic reaction, 1 to 6 hours after transfusion. Caused by cytokines in stored blood, fever and chills, but no hemolysis. Allergic reaction, mild, within minutes to 1 hour. Urticaria, itching, due to plasma proteins. Anaphylaxis, immediate onset, often due to IgA deficiency. Watch for hypotension, bronchospasm, shock. Acute hemolytic reaction within 24 hours. Serious. This is an ABO mismatch emergency. Features? Fever, flank pain, hemoglobinuria, and DIC. Delayed hemolytic reaction, days to weeks later, due to minor antigen mismatch. Look for falling HB, mild jaundice. TRALI, transfusion-related acute lung injury, occurs within 6 hours, caused by donor anti-leukocyte antibodies. It's a non-cardiogenic pulmonary edema, and it can kill. TACO, transfusion-associated circulatory overload, same time window, within 6 hours. But here it's volume overload. You'll see hypertension, dyspnea, bilateral pulmonary edema. Curious, sounds like heart failure? Exactly. Now, let's not forget transfusion-transmitted infections. HIV, very low risk today, less than 1 in 2 million units. Hepatitis B and C, routine screening is done. CMV, critical in neonates and immunocompromised. Malaria, always ask about travel history. Prions, VCJD is rare, and there's no effective screen. Chronic transfusions? Watch for iron overload, common in thalassemia major and sickle cell disease. Treat with deferoxamine or deferasirox. Monitor ferritin levels and do periodic liver and cardiac MRIs. And now, your preventive strategies. LUCA reduction reduces CMV transmission and febrile non-hemolytic reactions. Irradiation, essential for preventing graft versus host disease in immunocompromised patients. Washing blood products removes plasma proteins, lowers the risk of allergic reactions. Let's test your retention with high-yield PLAB, MRCP, and USMLE style questions on blood transfusion and its complications. USMLE style MCQ Q1. A 29-year-old woman with no past medical history receives 2 units of packed RBCs after delivery. Within 30 minutes, she develops fever, chills, and back pain. Her urine is red. What is the most likely diagnosis? A. Febrile non-hemolytic reaction. B. Acute hemolytic reaction. C. Delayed hemolytic reaction. D. Anaphylaxis. Answer B. This is classic for an acute hemolytic transfusion reaction due to ABO incompatibility, fever, flank pain, hemoglobinuria, and rapid onset. MRCP style question Q2. A 68-year-old man develops sudden respiratory distress and bilateral pulmonary infiltrates within 2 hours of receiving a transfusion. He has no previous cardiac history. What is the most likely diagnosis? A. TACO. B. TRALI. C. Pneumonia. D. Pulmonary embolism. Answer B. TRALI. Transfusion-related acute lung injury is rapid onset non-cardiogenic pulmonary edema caused by donor anti-leukocyte antibodies. PLAB-style question. Q3, a patient starts itching and develops a rash during transfusion. Vitals are stable. What is the next best step? A. Stop transfusion, give adrenaline. B. Stop transfusion, give antihistamines. C. Continue transfusion slowly. D. Send the blood unit for culture. Answer B. This is a mild allergic reaction. Stop the transfusion and give antihistamines. No need for adrenaline unless it progresses to anaphylaxis. Bonus round. Rapid fire recall, universal RBC donor. O negative, universal plasma donor. AB. TRALI versus TACO. What's the BP clue? TRALI equals hypotension, TACO equals hypertension. Iron chelator for chronic transfusions, deferocyrox. Most common transfusion reaction, febrile non-hemolytic confident. Keep drilling these patterns and you'll not only pass, you'll dominate. This is Medical Rocket. Subscribe, stay sharp, and we'll see you in the next clinical mission.